Hi there. So we are continuing our talk on diabetes, focusing on oral medications for diabetes. Now, if you have any questions about the disease state of diabetes, I have those slides earlier in the presentation. I have an explanation of those slides in the injectable diabetes video, so make sure to watch that one if you have any clarifications or questions about the actual disease state of diabetes mellitus. However, if not, let's get started and continue with oral diabetic medications. So the first one, the first line drug or the best starting drug for anyone with type 2 diabetes is what's called metformin or glucophage. Now, glucophage or metformin, they work in a very, very interesting way. It's a biguanide drug, which works in three ways. So it is approaching the disease state of diabetes in a three-pronged approach. Number one, metformin decreases glucose production in the body. So it makes your body produce less glucose itself, less sugar. So less sugar produced in the body helps lower that blood sugar in the bloodstream, that blood glucose as a whole. It also decreases intestinal absorption of glucose, as well as increasing the sensitivity to insulin to bring more glucose into cells. So it will take less insulin in people taking metformin to introduce that glucose into the cells. You'll recall I said insulin's kind of like a key into the lock that opens up the cell to receive that glucose from the bloodstream. So if you're not producing a lot of insulin, so you have type 2 diabetes, if you're not producing a lot of insulin or you've grown resistant to insulin, it helps increase the, I guess you could say, power of the insulin. So less insulin is able to do more in people who are taking metformin. Less insulin is able to introduce more glucose into the cells. That causes better glucose metabolism and lowers blood sugar. Now, we have to be cautious, though, with metformin in patients who have kidney impairment, because as you are, metformin works in the kidneys, it's metabolized in the kidneys, so it's often given at lower doses for people who have CKD or chronic kidney disease. It's hard on the kidneys as a medication in general. And of course, as you can imagine, especially with that decreased intestinal absorption of glucose. So if you're not absorbing the glucose in your intestines, that glucose from your food is simply going to stay in your intestines. Therefore, nausea, vomiting, and diarrhea are the most common side effects, as well as abdominal cramping or general gastrointestinal discomfort. So that's why, in addition to flatulence and other symptoms like that, or side effects like that. So that is why we always advise with metformin, take it with food, because that reduces the gastrointestinal side effects that you might be expecting with that medication. And metformin is available in tablets. So they're pretty easy to use tablets, although they can be a little bit large. You can have up to 1,000 milligram or 1 gram tablets of metformin. So it's kind of a big pill. But that's only if you need that much. The dosage can vary. Next, we have our sulfonylureas, which are other oral diabetic medications. Now, these are oral tablets which work by causing the pancreas to produce more insulin and to help the body use insulin more efficiently to remove glucose from the bloodstream. So cautions for this, they're only for use in type 2 diabetes, which makes sense, right? Because people with type 1 diabetes, their pancreas isn't producing any more insulin. All of those beta cells, they were taken out by the immune system when they were between 4 and 7 years old. So they're not able to produce insulin at all. So sulfonylureas wouldn't be of any benefit to a person with type 1 diabetes. However, they can be quite useful for people with type 2 diabetes who are still producing some insulin and just have to use it more effectively. Now, there's a risk of low blood glucose events or hypoglycemic events, hypoglycemia. It's probably the main side effect that you would have to be considerate of when using sulfonylureas. And also, do not use sulfonylureas if the person has a sulfa allergy. You've probably heard of sulfa allergies, quite common with certain sulfa antibiotics as well. But as you can tell by the name, sulfonylureas. They have a sulfa group in them as well, very similar in the group that appears, that sulfur atom that appears in the sulfa antibiotics. So they're allergic to those. Don't use sulfa pills with people who have type 2 diabetes and need to use sulfonylureas. If they have a sulfa allergy, avoid that. Now, main side effect of sulfonylureas is unfortunately weight gain, which very oftentimes is kind of a hard sell to patients who have type 2 diabetes and might already be overweight or obese. Nausea is also a fairly common side effect. However, these drugs are still quite good at lowering blood glucose, so they might be preferred in certain people or by certain people. Examples, the best way to remember sulfonylureas, they all start with GL and they end in the suffix IDE or ide. So glymetpyride or amaryl, glipizide or glucotrol, and glyburide or diabeta or glynis. Diabeta, really original name, right, for a pill for diabetes. Anyway, another combination medication is combining glyburide or diabeta with metformin, which is called glucovance. Now, that's really nice, right? So instead of having 2 pills to take, the person only has to take 1, and they get all the benefits of metformin as well as glyburide in a single pill. So that's really nice, especially for patients who have to take multiple medications per day. Next, we have our SGLT2 inhibitors. They simply work on a receptor in the body known as the SGLT2 receptor, and those SGLT2 receptors are in the kidneys, and they help by reducing glucose absorption in the kidneys. Now, don't have to worry too much about that. That's far too pharmacological, but just know that your SGLT2s reduce glucose absorption in the kidneys. Now, they have a few cautions and notes. There is, and this looks a lot scarier than it actually is, there's an increased risk for foot amputations with canagliflozin, which is the main SGLT2 inhibitor that we're talking about. Now, that's something that's known as a black box warning. That's something that occurred in a clinical trial when they were first approving the drug, and they said, well, compared to the placebo group or the group that was being treated with something else besides Invokana, canagliflozin, there was 2 more foot amputations in this group than in the other group. So we have to put that down as a potential side effect. It's a very, very minimal risk considering the amount of people who were in that trial. However, it is still important to know, and it might be one of those weird side effects or adverse reactions that pops up on your quiz or test. Now, dehydration due to urination, as you can imagine, SGLT2 inhibitors, they work in the kidneys, right? And your kidneys are connected to your bladder, and they filter the blood, so you get rid of all of the excess stuff when you pee. So the dehydration due to urination, they do make you urinate a lot. So people who take SGLT2s must make sure to stay hydrated. Now, also going off of that point, you have to use them with caution in patients who are taking diuretics, ACEs, ARBs, so those 2 blood pressure medications, any drugs that affect urination, which might cause an electrolyte imbalance, especially low potassium in the body, because that can cause some severe side effects and potential adverse effects that could be even life-threatening, or at least very, very bad for the quality of life of the patient. So they have to stay hydrated if they're on this drug. Now, side effects actually include notable weight loss, and that's just due to decreased sugar absorption, which makes sense. If you're not taking in the sugar, then you're not metabolizing it, and it's not being stored as fat anywhere in your body. So that's why a lot of people like Invokana, canagliflozin, and other SGLT2s, because they actually lose weight when they're taking them. But of course, hypoglycemia, that low blood sugar, as always with most diabetic medications, is a potential adverse event. Now, all of the generics of SGLT2s end in the suffix flozin, F-L-O-Z-I-N, and the only one that breaks into the top 200 drugs for you guys that you'll have to know is canagliflozin or Invokana. Now we have our DPP4 inhibitors, and that's just after another pharmacologic pathway that we're naming them after. They work by increasing substances in the body which help the pancreas release more insulin and signal the liver to stop producing glucose when there's too much glucose in the blood. So they're sort of facilitating that glucose metabolism in the body, as well as helping the pancreas along if it feels a little bit burnt out, because it's only used in patients with type 2 diabetes. Obviously, it can't act on patients with type 1 diabetes because they don't have any cells in the pancreas to make the insulin anymore. So you can't tell cells that aren't there to go to work and start making insulin. So DPP4 inhibitors are only used in patients with type 2 diabetes. Now we have a few cautions. There's actually, and I'm not exactly sure, to be perfectly honest, about the exact risk, but this was clearly found as one of the potential adverse effects, is an increased risk of upper respiratory infection and nasopharyngitis, or the inflammation of the nasal passages. or nose and throat infections with patients who are taking DPP4s. That is to say that obviously the caveat with our adverse reactions and adverse effects, they don't happen in everyone. They can happen in maybe 10% or fewer of patients most of the time. The most common side effect, however, in about 10% or more of patients is headache. Peripheral edema or the swelling of limbs, especially like the lower limbs, lower extremities like ankles and feet, that's possible with using DPP4s, as well as rash. And it can also cause pain and inflammation in the pancreas because it's working in the pancreas. So it can also cause pain and inflammation of the pancreas. So look out for pancreatitis or chronic pancreatitis. Pancreatitis simply meaning inflammation of the pancreas. Again, the DPP4s are very easy to remember because they all end in the suffix gliptin. So sitagliptin is Januvia, and sitagliptin / metformin, so a combo pill of sitagliptin and metformin, is Janumet. You can see right there, it comes in varying doses, varying sizes, also extra or extended release formulations. So many times people would prefer to take one pill versus taking a Januvia as well as a glucophage or metformin. We also have our thiazolidinediones, better pronounced and better said by me as TZDs. They are oral tablets which work by increasing insulin sensitivity. So they simply work by letting more glucose into the cells. Again, they only work for type 2 diabetes. They need some insulin to work in order to increase the insulin sensitivity. So it will do nothing for a person with type 1 diabetes. They're going to require insulin. But if a person only has type 2 diabetes, a TZD might be right for them. Now, what do TZDs do and what do we have to look out for? Well, the main problem that, or at least the chief complaint that a lot of people would have with TZDs is weight gain. Might also decrease cholesterol levels, which is actually a good thing. If they are obese or overweight, chances are the patient might have high cholesterol. So it's a nice little add-on, especially if they're already taking statin therapy for their cholesterol, that they might like to go on to a TZD. However, TZDs may also cause peripheral edema or the swelling of limbs, and they can also exacerbate or make worse symptoms of edema related to heart failure or myocardial infarction or heart attack. So if a person has an underlying cardiac issue, a TZD would not be for them because it could certainly cause more fluid buildup in the body when they're already experiencing that fluid buildup, maybe due to chronic heart failure or a similar condition. Now, it's also not recommended in people with a history of bladder cancer or tumors. So this is actually a big one. If they have a history or a enhanced risk for bladder cancer or tumors, it turns out that TZDs might, and I say this with the caveat that it doesn't happen in very many people, and most people are not at risk for these things, but if a person has a documented history with bladder cancer or tumors, you cannot give them a TZD because there is a correlation between using a TZD and the development of growths or neoplasms that are in the bladder. Now, generic end, or all of the generic ends, I should say, for the TZDs, they all end in glitazone. So again, very easy to pick out a TZD. They all end in the suffix glitazone. So we have our pioglitazone, or Actos, as you can see right up there, that PIO, and our rosiglitazone. And of course, they all come as tablets. So that is that for our oral diabetes medications. If you have any other questions, feel free to ask. Have a good one.